Good morning, everybody. My name is Janos Hajagos, and I'm part of the Department of Biomedical Informatics. And I'm going to focus in this talk a little bit more on the sort of underlying data, and coming from the data more from a perspective of working with the data, manipulating it. So one of the first projects that I did at Stony Brook was as part of a team, was a long-term project with the New York State Medicaid, and it was to reduce utilization thresholds for the Medicaid population in New York State. And it was a project that we did at Stony Brook. We started in about 2007 and ran through about 2012, and there we reduced the utilization thresholds using clinical criteria for the Medicaid population, and we ended up talking to their mainframe system and changing the thresholds for about 2 to 3 million people. That was the first project that I was involved with, which sort of used healthcare data, and that was administrative data, which is organized it's less detailed. After that project, I led the team that developed a website that's still being used today and still being developed, that allowed you to search formularies in Medicaid. So in Medicaid, there's multiple managed Medicare plans. There's about, I think, 18 different plans in New York State, and each one covers a different set of pharmacy drugs. And we built a system to integrate data across multiple systems and provide and allow you to search a drug and see which plans cover that drug. So that's how I kind of got into healthcare data. Before I was involved in healthcare data, my background is in ecology and evolution. I did my PhD in ecology and evolution across the street. And in some ways, in studying ecology, you study a lot of interactions of plants, animals, and in some ways the hospital is sort of like a kind of a complex system. And so even though I didn't train in medicine, what I learned in ecology and is helpful at sort of like dealing with those just range of different types of data that we have to deal with on every day. So that's sort of my background. Okay, so this picture is maybe one of the first, let's say, fake news, but this is a picture from the 1850s, the first picture of a battlefield, and this was from the Crimean War. And so this is one of the earliest pictures. Why I'm talking about the Crimean War is because of Florence Nightingale, which the hospital CEO also talked about. So I guess she's an important person, right? And she was in the Crimean War as a nurse. And in some ways, Florence Nightingale is sort of like one of the first healthcare data scientists. And as Dr. Pasternak said, she was interested in the organization of healthcare data and putting it into order. Some of her work eventually led to the ICD system, like ICD-9, ICD-10, in order to sort of organizing different diseases. One of the things, she was also interested in data visualization. And this is a visualization from the Crimea War. And this shows where they categorized how people died from wounds in the battle, from other causes, and from disease. And by organizing the data into sort of these broad categories, right, you can see a trend, right? You could see that, deaths on the battlefield is only a very small portion of the deaths that occur during a military event. And so, by organizing data into sort of categories, we can start to see trends and patterns. And this is, and that's why we want to structure data in a more organized way. Going 50 years forward from then, or 60 years, just another quote talking about hospital efficiencies. So even early, 20th century, they were talking about organizing hospitals' data in a more organized way. One of the differences between Florence Nightingale's quote and this one is that now I started thinking about hospitals more as a business system and then talking about management and efficiency. So really we want to organize data in a more structured way. So in 1970, this was a study that was published about small area variations in healthcare delivery. So what's interesting, I find this interesting because they talk about population-based health information system, right? So nowadays we talk about population health being something new, and this is population health information systems being everybody has got to get one. But this is the 1970, and they talk about population health systems. And the author, Wenberg, he established the Dartmouth Health Atlas. So this is sort of the early start of that. And in this study, they looked at healthcare delivery in the state of Vermont, and they noticed that there was differences and variations in healthcare delivery in the state of Vermont. So you can see that there's differences in surgical procedures, respiratory diseases, beds per person. These are things that we all compute now and work with when we look at hospitals. So population health is not new. It's been going on for a while. This is data on length of stay. So as hospitals became more sort of an enterprise, we measure like different outcomes. And one of the outcomes that's important in healthcare delivery is length of stay. That is when a patient gets admitted and when they are discharged. And this is data from Medicare. And they start with 1981, and then they jump to 1984. What happened between 1981 and 1984 is, it wasn't called CMS at that point, I think it was called the Healthcare Finance Association. They put in DRGs. DRGs are called diagnostic related groups, and they're a way to organize your admissions or discharges in a hospital by categorizing them into categories. And then they go up to broad types like medical, surgical, or psychiatric. Actually, what's interesting, I found that the DRGs, the basic research for DRGs were also around the early 1970s. It took about 13 years for them to be put in place. And what you notice now is that in 1984, right, you can see down that the length of stay decreases. And this is because the way they were paying, right? So on a DRG, you get paid a flat fee, and if the patient stays longer, you don't get any additional money. So that was a way to sort of control cost in healthcare systems and in inpatients. So you can see that there's a reduction in and the DRG spread from, from Medicare to Medicaid, and now it's also they have DRGs. They use DRG systems internationally too. So it's been a sort of established system. Okay. So I'm going to talk a little bit about opening healthcare data. And if you've been working in healthcare, you know about what's called HIPAA, you know about data privacy, and you know about the challenge of working with healthcare data. If you want to do research, you need to get an IRB. But there's been a recent trend to make some of the data in healthcare available more freely to access. So in 2013, I think it's the past health commissioner, Dr. Shah, received an award at a conference called the Health Data Palooza, which is a conference that's run in DC, which is about opening like healthcare data and utilizing healthcare data in a more efficient manner. And the reason he got this award was because of the work that was done in New York State and New York State Department of Health to make data that New York State has available publicly. So some of the data that he made available is a data called Sparks. Sparks is a data set which every hospital in New York State has to submit to. So as part of their licensing in New York State, they need to submit detailed information about each discharge from the hospital. Everything down to the address, the name, the diagnoses, procedures done, lengths of stay. It all gets submitted to New York State Department of Health. What Department of Health did in around 2013 was they released that data in a abbreviated format. So we don't get all the information that we would get if we got the full Sparks, but we get enough information to start to do some interesting computations with. And you can see the URL up there, and so anybody can go to this health.data.newyork.gov and get data about all discharges in New York State. And I think they just released the 2015 data. And so in this example, what I'm going to look at data related to kidney transplants. So by extracting this data, I can extract the data, and we can see that, it's hard to see up there, but there was in 2014, there were 1,169 kidney transplants done in New York's hospitals. And we're going to look in detail about those discharges. So one of the reasons why I picked kidney transplants, because it was an easier sort of, there aren't that many actually hospitals in New York State that do kidney transplants, right? There's only 13 hospitals that are certified to do kidney transplants in New York State. So it's sort of a nice example to look at because there isn't such a large volume of data that it becomes difficult to look at. And this is looking at the length of stay. So length of stay is a good metric for sort of correlated with quality of care. If you're more efficient, less things go wrong, the patient should stay a shorter time in the hospital, right? So it's a good sort of metric for quality of care. In detail, it could be more complicated because the patient can come in with comorbidities. But you can see that among the 13 hospitals in New York State, there's a pretty good variation in the length of stay for a patient getting a kidney transplant, right? So, so we can see the sort of the variations in the length of stay. And this was all done with public data. So I didn't have to sign any non-disclosure agreements or do any IRB assessment for it. And so what you can see is that when we look in detail, right, we can see the individual hospital. I didn't put that in the last plot, but we can look at the mean length of stay, the number of discharges, and we can see that there's, we can see Stony Brook, you can sometimes see the history in these databases, right? In the Sparks data, it's called University Hospital. And so you can see where Stony Brook compares to other hospitals in New York State in terms of lengths of stay and number and the volume. And you can see that the New York Presbyterian Hospital, together with Columbia, they do most of the kidney transplants in New York State. So one of the hypotheses, right, that we talk in terms of volume in surgery, right, is that that the greater volume, the better the better the quality of care. And so here I did a very simple analysis. I took the volume of the transplants performed and the mean length of stay and regressed a line against it. And this gives some evidence out, maybe in this case, that it's true. But the point here is that I did all this analysis comparatively, looking against other hospitals in New York State. I didn't need to access any private data, and even though I don't get every piece of information that I could need for a more detailed analysis, there's enough data, there's enough information in this data set to do some pretty interesting comparative research work. And Janos is here in the back. He's been developing a tool to make this data more accessible and more interactive. I used a tool called Jupyter Notebooks and Python to do the analysis. but he's been developing a tool to make it more interactive data exploration. So that's some of the other work that we're doing in biomedical informatics. Okay, I'm going to switch gears a little bit. Even though healthcare data has been around for, like healthcare, like data analysis, let's say from the 1850s, right? What's different now is the volume of data that's being captured. And before, most of the data was administrative data that was captured, so billing data. And you can see here's the price of our electronic health record vendor stock price, right? You can see that mostly through the 2000s, the stock price stayed relatively flat. And then at about 2008, the stock price started to go up pretty significantly. And part of the reason the stock price went up significantly is because that's basically when the federal government, through the ARA program, started to subsidize electronic health records for hospitals. And so you can see that as the hospitals, bought more products, right, certain stock price went up. So it's really this sort of 2008 is really when we started to really have pretty good penetration in terms of having electronic health records in most US hospitals. And this is data from Health IT, the Gov organization. And you can see that this is from 2015, right? So nowadays, most hospitals, right, 96% have electronic health records across, all hospitals, small, rural, critical access. And you can also see that for the physician outpatient, right, we're still not at the same level as the inpatient hospitals, but most physician practices, now have some form of electronic health record, and if they don't, they probably will be potentially bought by a health system that does. So I expect this number to, over the next 5 years, to probably get very close to 100%. So really, we're collecting more and more data about what's happening with the patient. And we're only beginning the process now to start to analyze that data to gain insight from it. So one of the tools that Dr. Pasternak talked about, Tableau. Tableau is a sort of a front end to data that makes it make dashboards and different visualizations. But you need to have a data store to store the data. And I think it's been about 4 years that Stony Brook adopted a technology called Healthy Intent. Healthy Intent is a product from Cerner which sort of stores data from different electronic health records into a population health platform. And this is the interface that I use to analyze and work with the data. What you can see on the right, is sort of how we, in this case, speak to the data, right? How we ask questions of the data. And if you're not familiar with it, this is called SQL, which is a language that allows you to query relational databases. And so all the data from our electronic health records and from Southampton and from some of the most of the practices get sort of integrated into this healthy analytics platform, and then we can query that data.
Just a question.
Yeah.
On the previous slide, when you said that as far as the EHR adoption, there's still like the 7 levels of completeness, right? Level 1 through 7.
Yeah.
Like the 96%, is that like people that include hospitals that just started their contract, or are they, where are they on the?
I don't know if it says I have to go back and look at the footnotes from the URL.
That's a pretty high number.
Yeah. A certified EHR. So they have to have a certified EHR. That's not, I think it's probably the most basic level. So yeah, when you look in details, right, the adoption and the level, where different hospitals are in their adoption vary. And even hospitals which some of the hospitals had their own homebrew electronic health records, like I think Columbia had their own system. And then they've now migrated to a more modern. So it's definitely an area which different hospitals are at different sort of levels.
That seems to be the
Yeah.
product, but it was too cost effective and cumbersome to continue that even on a big, center of excellence. So they moved on to that.
Yeah, and I think part of it is that the sort of like the complexity of the systems to integrate with, you have to integrate with every type of device, right? And it just becomes impossible for even a very wealthy hospital to keep up with it. So this is some very basic data that I ran this week from the Healthy Intent platform. And this is a query where I'm just looking at the results. Like a result could be a blood test. It could be an answer to a survey. It could be a blood pressure. These are all results. So you can see, and this is our data, which includes data from Southampton and outpatient data and inpatient data, right? So you can see that in 2012, and this is data on a per month basis, right? So you can see that in 2012, we're 2.5 million records results per month. And then we can go up to today, right? We're 6.5 million, almost 7 million records per month. So you can see that over this last 5 years, right, the amount of data that we're capturing of the healthcare system has increased pretty significantly, right? Then we can also look at the number of patients, right? So we can look at increased number of patients, right? So in 2012, most of the data capture was related to inpatient data. In 2013, 2014, the outpatient clinics started to come online. So you can see that on a per month basis, and this is a good proxy for the number of sort of patients that are touched by the healthcare system. So even if you get a body weight, that counts to the result, right? So you can see that on a per month basis, our healthcare system is, about 70,000, between 60 and 70,000 patients are interacting with the healthcare system. And this was based on on this very basic query that I showed before, right? So we can look at this very basic data and start to see trends. We can also normalize that data, right? Which is interesting to see that the sort of volume, most of the volume increase is driven not by capturing more data elements, but by the increase in number of patients. And then we can take the same data set, right, and then we can look at the volume daily, right? So we can look at the volume of result on a daily basis. And I pulled this from, this is September 1st, right, which was a Friday. This is the Labor Day weekend, right? So you can see that that after that, right, we have a dip, right, and then goes back up to the daily. So same data set, right? Before we could look at it and look at how the volume in the hospital is increasing, but if we look at it on a daily basis, right, we can see how our volume, changes on a daily basis. And then we can even go down to the hourly level, right? So we can look at that same results and how they're captured on an hourly level, and we can start to look at trends in terms of where the health system has its most, data is captured, right? So you can see that at midnight, 0 hours, there's, not that much data captured, but, but the morning hours seems to be where the peak data capture happens, and then it decreases as our outpatient clinics close, right? So I went to this example to show that a single data set, right, just looking at counts of results, we can see a lot of different pictures of how healthcare, and I think that this type of data, as we start to do more analyses, is going to lead to more insight into how the healthcare system is working. One of the things that DRGs did was they organized patients into categories, right? So one patient is one category, right? So you have, kidney disease or you have diabetes, and you're either one or the other, right? in reality, patients have multiple conditions, right? So this is a simplistic look at patients, but now with new information tools, we can look at patients in a more complex and complete way. In reality, right, this is an analysis that we did for Medicaid, for the district projects, looking at comorbid conditions. So you can see that patients that have different conditions have different other diseases, right? And we can do this even for one condition, two conditions, three conditions. Here we're just showing two. So you can see that the patients that we see in inpatients, have complex comorbid conditions, right? So the look before in data, we looked at kind of put into big groups, but now with the increasing volume of data and increasing ability of tools to split apart the data, we can look at patients in a more complex and complete way. And so in reality, we have a sort of a matrix where we have patients can have not just one condition, not just two, but they can have multiple conditions. And then we can start to work and analyze this data set in a more complete way. Another thing we can do with healthcare data is we can look at how so there we're kind of looking at large scale patterns. We can also look at how patients go through the healthcare system. So we capture data about when a patient moves from one location to another, and we have the timestamps for that. And we can use a tool which sort of allows us to sort of track patients through the hospital. And this is a tool developed by Ben Schneiderman, who was the first CS PhD graduate from Stony Brook. And we can kind of zoom in on this, right? And we can see here's some analysis we did a couple years ago, where a patient was when they got an infection, right? Tested positive for infection. And so we can do analytics. So we can zoom down to, the individual patients, how they move through the healthcare system in detail, and we can analyze this data. And, it's hard to find, it's interesting, and we still struggle a little bit with trying to figure out how do we take this very detailed information and draw larger conclusions from it. But we have the ability to sort of zoom in on a single patient, look at how they go in the hospital system and what events happen during that process. I think in general, we're very early on in the process of trying to use this electronic health record data. And I think, maybe it's going to be in 10 years where we can really fully use it to its full potential. Another way of looking at the data is that we can look at where the patients come from. So we have information in Health Analytics about their address of the patient, right? We use a technology called geocoding, which allows us to pinpoint where the patient is, and we can then aggregate where those patients are to what's called a block group, which is a unit that's used in census. And we can use a tool like a mapping tool to look at where the patients come from. So these are patients that were seen in Stony Brook with a cancer diagnosis, and we can see where they come from. Some of the highlight areas out here, when I looked at the map, where they were senior communities. So you can kind of see where the patients come from. And here we're just looking at it very broadly at people who have certain diagnoses, and then we're geolocating that to the map. So we're not looking temporally at the data, we're looking spatially at the data. We developed a tool, Janos also developed a tool with another research scientist here to make these maps more interactive, that you could zoom in, zoom out, and use a web-based tool for that. And then we can connect the data about our patients to the communities that they live in. And this is data from the Census Bureau, which shows different demographics on the community at the same sort of spatial scale of the block group. And this is a map of. So if you ever have a chance to see Janos demonstrate some of his tools, this will come more alive. But this is just a snapshot of it. And then this is, the same map with different parameters, right? So we can look at per capita income, right? So we can highlight areas that, have lower per capita income, and we can see where our patients come from and what are some of the challenges they might have in their healthcare delivery. Okay, so the last talking about data, healthcare data. So we have different healthcare systems, and we're putting them into a single database, right? But every healthcare system is doing it in a different way. So everybody now is buying healthcare, getting electronic health records. They're also buying systems like Health Intent to aggregate data across multiple systems. But every system uses a different database. And so if we develop a tool here at Stony Brook, it might not be applicable to another healthcare system. So everybody has to sort of reinvent the wheel to do their data analysis. There's been an interesting project that started out of the FDA in sort of post-market surveillance of drugs after drugs are sort of approved and on the market to detect when there's adverse events. And the example that they sort of gave them, like the kick in the boot to start this, was this Vioxx, which caused cardiac problems after it was approved for use. And they developed a standard data format so that they could look at, can we detect the next Vioxx? And can we look across multiple data sets to test our methods for detecting something like an adverse event? So initially they were very focused on drugs and drug events, but as their data model started getting picked up by other users, because it was nice to have a common data model, the analytic use cases of the data model have increased, and now people are using it for a range of different approaches. And here's some work that we've done here in the Department of Biomedical Informatics of mapping our own healthcare data into this common data model, which by doing this, we can use some of the analytic tools that were developed by the Odyssey group, which includes a lot from major pharmaceutical companies and from other institutions. We can start to use the tools that they develop by putting our data into a common data format. And this is some of the work we're doing here. So I think we're at a very early phase with healthcare data and electronic health records that we're just starting. It's like really, we started in the outpatient in about 2013, 2014. So it's really been 3 or 4 years that we sort of have almost, let's say, 100% capture of what happens to our patients in our healthcare system. And we're still very early on in the process. And I think as we want to start to use this data for clinical research, it's going to be there's a lot to learn. There's not and the data in reality is messy. And when you get down to actually working with the data, you find that you spend a lot of time cleaning up the data, manipulating it. And I think as sort of a challenge, right, for the next 10 years, I think we're going to it's going to take about 10 years to sort of like be able to use this data in a more efficient manner. So, I'm excited to have everybody here, and, that people start to think about all this data that we're collecting and how do we start to utilize it for improving clinical care and research at Stony Brook. So that's, any questions? Yeah.
Hi. Going back to a slide you had earlier regarding a specific patient where you drilled down to see when he got an MRA, MRSA infection, etc. That's the kind of information that clinicians need in real time.
Yeah.
That we have a very hard time extracting from Cerner.
Yeah.
Often we need trends. We need the big picture and the telling us that. Is there any thought to having that capability for clinicians in real time?
Yeah, so this tool that I'm showing you is developed for like sort of post-hoc analysis of the data, right? And it's still sort of an active area of research on how do you develop a tool for looking at these type of events. But it would be possible, using some of the how data is displayed here to make that more real time.
Yeah, 'cause right now we might say how many weeks have they been on a ventilator?
Yeah. So one of the challenges is getting data out of the electronic health record in a real-time fashion. And now, right now, we sort of have to do some, stretch back this way and do some weird stuff to get the data out, and it's a lot of work. But there's a technology coming out called FHIR, which makes it easier to extract data out. So with an interface from FHIR and a tool that can visualize sort of these time-based events, it should be easier in the next 2 to 3 years to develop these type of systems. And the nice thing about FHIR is that it's a data model which will be applicable across different EHRs. So it would be possible that somebody could develop a product that could be used, develop it here, and then they could use it at other hospitals. So that's where things are going, and I think we're all excited about it. But
Janos, could you speak a little bit to why it's hard to get data out of the EHR?
it's hard. Well, it's hard because there's a couple reasons. So we have in our real-time EHR, right? It's designed to